Welcome to episode 2, season 3 of Diabetes Health Matters. My name is Dr. Joan St John and I'm the host of this webinar series. We're delighted to present this webinar series to you, which is produced by Diabetes Africa and sponsored by Eli Lilly and Company, although they have no input into the content. We're going to be talking about diabetes in children and young people in this webinar today. And we're going to be talking with Davina Jean-Jacques, who is a children's diabetes specialist nurse. And she recently won an RCN award for her local trust. And she won this award because she was able to improve the outcomes of children and young people living with type 1 diabetes. Now, let me give you a bit of background. Davina works in an area where there's a lot of socio-economic challenges, there's a lot of diversity in terms of ethnicity, and she and her team have achieved equity of outcome in the children and young people from this area living with type 1 diabetes, which is actually quite a phenomenal achievement. So, it's important that we talk about this subject. It's important that we see how we can address and improve outcomes, achieve equity for children and young people living with type 1 and type 2 diabetes. One quick fact before we start to talk with Davina: children and young people living with type 2 diabetes now number about nearly 170,000 within the UK, and the rate of increase of children and young people living with type 2 diabetes, which is normally associated with an older demographic, is actually, the rate is increasing. So Davina, welcome. It's fantastic to have you with us. We haven't had a paediatric diabetes nurse specialist before, and we're really looking forward to hearing about diabetes in babies, children and young people, and also about the amazing work that you've done in your unit to provide equity of care in terms of the technology and providing that technology to children and young people living with diabetes. So welcome, Davina. And I think first of all, you're going to tell us about diabetes in babies, children and young people. Over to you, Davina.
Thank you so much. So I just wanted to really just go through a little bit about diabetes that we see in children's services. The most common type of diabetes that we see is type 1 diabetes, which most know is when the pancreas is not working, and those, which is an autoimmune condition, requiring insulin treatment through insulin injections or insulin pump therapy. We also see those with type 2 diabetes. This is when the pancreas is working. However, there is insulin resistance. I just wanted to take a bit of time also just to say that we do see other forms of diabetes, but it is more rare. So we do see a few with monogenic forms of diabetes, which is more genetic. We see cystic fibrosis and steroid-induced, as well as type 3C, and so many others. But we predominantly see type 1 diabetes in children and young people.
So Davina, that's quite different to what we would see doing an adult diabetes clinic, isn't it? Because you said the majority of children, babies, young people that you would see are living with type 1 diabetes, whereas in an adult clinic it would be the reverse. It would be more 90 to 95% would be living with type 2 diabetes. Do you want to just say a few words about that?
Yeah, exactly that. So you would find that your adult teams tend to have a higher population of those with type 2 diabetes, and they see the type 1 slightly less. So usually, although you can be diagnosed with type 1 diabetes at any age, you are usually diagnosed in childhood. So our highest population is type 1 diabetes. We are starting to see more type 2 diagnosis, which I'll kind of show you a bit later on, but predominantly type 1, and that's because of the autoimmune condition.
And I think the other thing that people would be surprised about is the fact that you can see diabetes in babies as well?
You can. So the youngest that our service has seen is 14 months old. We have had some services that have seen diagnosis at 7 months. And then where I touched on a little bit about the genetic types is that you can have neonatal diabetes, which is quite rare, but it is there.
Yeah. And if I can just give a little bit of explanation for those who may not be fully aware. So autoimmune is when your body's immune system is not recognizing bits of itself as being of itself. And in this case, it's the pancreas, and it produces antibodies against itself, against the pancreas, and destroys those insulin producing cells in the pancreas. So people living with type 1 diabetes, because these insulin producing cells are destroyed, require insulin treatment in some form or fashion, as Davina said. Whereas with type 2, it's not an autoimmune condition, it's insulin resistance. So the insulin is not either working properly or there isn't enough of it, and that causes the high blood glucose. And then the monogenic is specific genes which are involved in the development of diabetes, so the high blood glucose caused by specific genes which we can recognise. So thanks very much for that, Davina. And can you tell us a bit more then about the sort of manifestations of diabetes in babies, children and young people? What might we notice? Is it going to be the same as adults, or does it look different? And what should we look out for?
So I think it's really important to know what kind of the basic symptoms are, which a lot of us kind of have an idea about, but hopefully I can kind of tell you what that would look like in a baby. So always really important to remember those 4 T's, which is thirsty. So drinking a lot, and it's an uncontrollable thirst, feeling tired a lot, thinner, losing weight, any kind of notices in weight loss. And I'll kind of go a bit more into what that would look like in a baby or a small child, and also toilet. So really remembering those. Now in a baby, what you may possibly notice, and this is more for type 1 diabetes, because the youngest that we've seen with someone with type 2 is around 8 years old. But your type 1, you're looking at frequent wet nappies. So if you're changing a nappy every couple of hours, every hour, and they're really full, heavy nappies. If the baby is more lethargic and tired, if they're crying and they're irritable because they're thirsty, you're feeding more often, however, they're not putting on weight. Really important to kind of seek that medical attention for them, because at that age they can't tell you that they're feeling unwell. So that will be your first sign, is those frequent wet nappies. Okay, we don't want to get to the point of signs of dehydration, which can also happen with diabetes. You can also get more frequent UTIs, so urinary tract infections, so urine infections, thrush and genital itching. You may hear from the school that your child is looking more tired in class, they're not concentrating, their behaviour has changed, because high blood sugar readings can cause children to become irrational, to become a bit more angry and upset. So that's really, really another important one to know, is that diabetes can actually change our cognitive function and behaviour depending on the blood glucose level. So if they're high, you're going to see a behavioural change in your older child. Okay, with type 2, you will have those symptoms, possibly not too much of the weight loss, but I just put a picture up there on kind of the upper right hand side, and it might be important that, you know, if you do see a darkening around your child's neck, under the armpits and the groin area, please also get that checked out, because that is also a sign of insulin resistance. So if you're seeing any of these signs, you can get a GP appointment if you can on the day. Ask them to check a finger prick. That's really, really important. Urine glucose, they're not very accurate. Ask for a blood glucose check. However, if you are seeing some urgent signs of your child being unwell, please go to your local A&E. We don't want this to, if this is a diagnosis of type 1 diabetes, it can result in something called DKA, which is diabetes ketoacidosis. That's when the blood becomes acidotic. And it can cause some very long-term complications.
It can unfortunately be more serious than that. And we don't even want to think about the implications of that. And the heavier nappies is a really good one, isn't it? For people to be aware of and to recognise, because in a baby, it's so hard to might not even notice the increase in thirst, or the tiredness. But I mean, a well child is not normally that tired and that lethargic that they need to rest, but it's that sort of degree of symptom we're talking about, isn't it? And they don't normally lose weight, which is the other thing. So sometimes people, when you look back, they think, why did I not recognise that? But it can be a bit insidious until it gets serious. And Davina, you've outlined so well, we don't want that presentation, that insidious presentation, to get to the serious stage where a child is rushed to A&E. Certainly at the GP surgery, they can do a blood test. They can also test the urine for something called ketones, which can be an early sign of this diabetic ketoacidosis. So although there's the similarities with adults in terms of some of the symptoms, it looks very different in a child, doesn't it? And you've really outlined those things. Blurred vision in a child is not something that they're going to normally have, and that should be a red flag. Yeah. So thanks so much for that. So signs and symptoms. What else can you tell us about diabetes in these babies, children, and young people?
So I think it's important as well that, once we get to diagnosis, which is once you've brought them into hospital, it's about the continued support that we can offer for the children and for the families and the parents. So it's about offering that psychological support quite early on. It can be quite upsetting to get a diagnosis such as diabetes. There's a lot of kind of myths, taboos and concerns that we have around them, which I'll go on to a bit later. And there's worries about the future that, your child's going to have. So, in terms of that support, we always try to kind of demystify what a psychologist looks like. and it's just about making sure that families know that they can have somebody to talk to when that time comes. So our team in particular, we always make sure that a counsellor or a psychologist goes up and introduces their service to the team, to the child and family. And they normally get an appointment 6 weeks later after diagnosis as a follow-up, and that's mandatory. We also provide education for the schools, able to support these children and young people, especially if we have a baby. We have to go into the nursery, teach them how to give injections, and support the family to check blood glucose readings, and to provide support for the family, really. We also do regular education. I think education is really important. I think that's the biggest thing that a lot of people kind of miss out on. They get education at diagnosis, but I think sometimes the diagnosis kind of blocks out a lot of things for people. So we try to revisit that quite often. It's also important to educate through the milestones as well. So as a child gets older, it's about kind of changing the education for that age group, and also continued education for the family, always revisiting your basics. That's so important, revisiting your basics and giving continued education and informing the families of the most up-to-date medication and care plan available for them.
And Davina, I know that education is your real passion. So the education is for the child who's living with the condition, but you've also said education for the families about the condition, and you've said education for the schools, because the child will be obviously at school. Again, a difference between a child living with diabetes and an adult living with diabetes. Child's going to be at school for a great part of the day. But do you also advise and educate schools about what to look for? Because we spoke about symptoms and signs. So do you do some wider education even than we've spoken about already?
Yes, so we actually offer monthly education for schools. So we give the schools a space to come into the hospital. Once a month, we try to get as many in as possible. And we go through the 4Ts. We go through demystifying diabetes, how we can support families. We also talk about, as well as kind of that medical support, that, administering medication via the technology or injections. But we also look at how schools can psychologically support a family. Especially in the area where there is social deprivation. Do we need to involve key workers? Do we ask, how do we work with the schools to improve a child's outcomes? I think so. That's really important.
I'm fascinated to hear more about that, because I know that you've got amazing results in terms of using technology to ensure that people are given equitable care and achieve the equitable outcomes, which is just like astonishing. So I was interested to hear that you said about the psychological support is mandatory. Is that in all units, or is that one of those key things that your unit might be doing different to others?
It should be available in all units. Unfortunately, it's not equal across the United Kingdom. But I think a lot of units are aware of it, especially in children's care. So we follow the NICE guidelines, and part of that is that every diabetes team, every children's diabetes team should have psychological support. It doesn't always happen, but we try to make sure that that is a must and it's mandatory.
All right, so we'll hear more about how you're doing the great work that you're doing, because you've said about providing technology and so on. But before we go on to that absolute golden nugget or nuggets I should say, tell us a bit more about what you're doing within your unit and what your unit looks like as well, because some people may not know. You work in North East London. What does your population look like?
So our population, so this is a really clear graph of our population here. So we are in the blue. So we have a high kind of ethnic population. So we also have a population that has a lot of deprivation also. So we've worked really hard, which we'll show you later on, in making sure that our population has the same outcomes as the rest of the United Kingdom.
You've got, a familiar London major city look really to your population.
Exactly, and a lot of that comes with your kind of language barriers, a lot of cultural differences, learning just the diets, what people eat, their daily routines. Diabetes treatment is not the same for it's not a bracket. It doesn't mean that one thing works for everyone. You really have to kind of get to know every single person, every single family, to basically give them the right care and support. I just wanted to kind of show on this graph about one of the challenges that we have in the paediatric population. So earlier I talked about us mainly focusing and having a high population of children with type 1 diabetes. But as you can see on this graph, we have had a huge increase in the number of children being diagnosed with type 2 diabetes very recently. In our particular unit, I will say that the majority of those are from Black and other ethnic backgrounds. So I think we have a lot of work to do within the paediatric populations.
Yeah, and that work is going to change, isn't it, Davina? Your focus, as we said at the beginning, is more on type 1, people living with type 1 diabetes. But over the coming years, it would appear, because your unit hasn't been unique in this, that there has been, sadly, a huge increase in children and young people who are now living with type 2 diabetes. So the pattern is, the appearance is going to change for units. And as I say, you have done some amazing work, which we're looking forward to hearing about. But I know that you're going to bust some myths before we get there, but we just are looking forward to learning those golden nuggets about how we provide that equitable care, because everyone wants to do that, but so few people are doing that. Myths and taboos, and then technology.
Exactly. So I think a lot of these myths and taboos are things that we've kind of heard before, and we've probably heard some of our family members say as well. And this is actually part of our project, was kind of gaining trust with a lot of our families and trying to bust these myths. It was about kind of normalizing just a healthy diet, not stopping sugar. We always say, if you want that donut once a week, have that donut. And I think the biggest thing is that it's not your fault. That is our biggest message from our service. We like to tell our families it's not your fault. We can work through this. It's just about having a healthy lifestyle. For those with type 1 or type 2 diabetes, it's about telling them that you can still have a healthy life. You can still have the job that you want. You can still be educated and live that normal life that so many people worry about. So I think I was having a think, and we do also get, especially with our kind of ethnic minorities, is we do sometimes get compliance issues with medication, and some of that is about working with medication. It's that holistic approach that people like to use. They get very scared of medication, and they worry what the medication will do to their bodies. So we try to work really hard with them on that, in demystifying and educating them on the reasons why we provide them with those medications. We do hear, I can pray this away. I'm not going to take my medication because God will take it away. And we try to work with, religion, and that, it's okay, but we still need our medication. We still need to live a healthy lifestyle.
And as you said, I think it's about that holistic approach, isn't it? So, faith is complementary to health, and it doesn't have to be something separate. You can incorporate it into the person's care, into their treatment plan, because they can share their health with somebody else. Their health information that they've received, they can share that with their church, with their mosque, with their place of worship. Is it the families that are saying these things to you? Because it's slightly different, isn't it? Because as an adult living with diabetes type 1 or type 2, you may be making the decisions. You may be having the informed choice. As a child, is it the children that say this? Is it the parents of the children that say this?
We get a mixture. So it will usually start with the parents. And then as the children get a bit older, we find that they then take on those same beliefs. So we try to, depending on the age of diagnosis, this is obviously if they're a bit younger, then we try to kind of work really intensively with the families while the child is young. And we talk about the importance of impressions and having a healthy thought process for your child. We do try to work with the adults quite a lot, and if we can't obviously get through to the adults, then as the child gets older, we tend to work with them a little bit more independently. We have actually worked with churches as well. We did have a specific church where the pastor was telling the family that we can pray this away, stopped giving the medication. But I think that just took a bit of education to the pastor, and then he was able to actually understand the work that we were doing, and we worked together to get that child to the place where they needed to be, and they're doing very well.
That's wonderful to hear. That is absolutely wonderful to hear. I think we're encroaching on these golden nuggets, and I think, which is fantastic. And I think you need to share with us why your unit has won awards, because if I say it is scandalous, the lack of use of technology in Black, Asian and minority ethnic communities, global majority communities, children and young people in this country. Unfortunately, the figures in the National Diabetes Audit year after year consistently have sadly and tragically shown that we are underusing, compared to other populations, underusing these technologies. And it's found that these technologies help you to have those outcomes, things like the blood tests, that will help you in the future to live a healthier life. So, many people want to provide the best possible care. They want to provide equitable care. Your unit has managed to do that. And you've got to share with us, Davina, how you've managed to do it. I think you've given us some hints. Just that example there of going and working with that pastor is, I think, one of them. But please share with us what's been happening, what the figures show, and how you guys have been able to do it.
So, I can show you the figures first, which is right, on the screen right now. This is our local unit, and this shows you that, if the work is put in, it can be done. I did kind of touch on a few things of what we've done, and I'll go on to the next slide and share a bit more. But I just wanted people to really take the time to look at the results that really, if you put that work in, you will kind of reap the rewards, and your patients with, Black and ethnic minorities can do just as well as anyone else. We have a high number of patients from those minorities using technology, but that's because of the extra work that we've had to put in. It may be that a lot of these patients are not going to their appointments. I've heard of teams doing access to technology days, and they usually say that's our way of getting people into the service. That's our way of teaching people the technologies. But the actual reality is that if people don't have an understanding of these technologies and they don't trust their teams, they're not going to go to the events. So it's really, really important to outsource, go to the families, do one-to-one work, and try to just demystify a lot of the barriers.
So in terms of the barriers, where do you start? Because presumably your figures in your unit were the same as most other units, but you guys have decided you're going to address it. Where did you start?
So I think our biggest thing was we saw that we had a lot of our Black and ethnic minority families had our highest HbA1cs, and that's the blood test that we do. Every 3 months. We do them in the paediatric population. I think in the adult population, they do them every 6 months.
It varies, 3 to 6 months.
3 to 6 months. So we do them quite often, and we were seeing that. So the national target is for it to be around 48, and we class a really high HbA1c to be above 69, 70 within our service. And we tend to give that population extra support. And we found that a lot of those were from your Black and ethnic minorities, and they weren't accessing the technologies, and they weren't as compliant with medication. So what can we do to engage the families? And I think these challenges are kind of across all paediatric teams. I know a lot of our networks in London are talking about strategies. There's been some amazing work all around. And we're just hoping that we can kind of do a bit more. But, one of these is that we've got a high number of type 2s. So it was looking at how do we engage these teams. So we looked at ethnic backgrounds. We looked at the cultural norms for people. That can be a huge challenge, looking at those cultural norms and how do we bring them into kind of the Western culture per se. How do we introduce them to technology and make them feel confident? And how do we make type 2, especially type 2 diabetes, not so normalized in a lot of these cultures? So I know, for example, we had an 8-year-old young girl diagnosed very recently with type 2 diabetes, and it was very normal for the family because mum had type 2, dad had type 2, auntie, uncle, and it was almost kind of laughed out. It's normal, it's part of our family history. It's about how do we break these norms, how do we really get to the crux of this? And it does take that extra time to go into the family home and support them.
So you literally went into the family homes, presumably had to build up some trust before you did that.
Yes.
Yes. And then practically, what did you do?
So for this particular child, I, in a very nice way, went through the cupboards, the fridge and the kitchen. We looked at the size of plates, we looked at the size of bowls, and I asked this particular child, you know, what type of cereals do you have? What type of foods do you have every day? Can you show me your portion size? And, you know, provided they did have loads of training before leaving the hospital, they'd seen a dietitian for about 2 to 3 hours, sat down, went through portion sizes and, you know, your usual healthy lifestyle kind of exercise things. So I made her show me how much Cocoa Pops, that seems to be the norm, Cocoa Pops for a lot of kids.
There are other cereals available.
There are. I do try to educate about healthier cereal options as well. So we did do that discussion about healthier cereal options. And that was actually quite good for me as a health professional as well, to see what people were doing in their homes, that what they tell you in hospital isn't necessarily what they do at home. So it's about taking that non-judgmental stance. It's about understanding and coming from a supportive angle. It was also show me your dinner, showing them what a normal portion size looks like. So we know in kind of these, in Black and ethnic minorities, we love carbohydrates. We love carbohydrates. And it's, okay, how can we reduce this? What swaps can we make to make the food healthier? And it's about, I think the importance is as well is that it's not just a child who has diabetes, it's a whole family change. We need to change the family culture. So it's inviting aunties, uncles, brothers, sisters into that household to teach them about the importance of a healthy lifestyle.
So Davina, you know, before we go on to talk about the technology, which we're dying to hear more about, can you just set the scene for us? So we know that not everybody is entitled to use these new technologies. Can you tell us a bit more about who is entitled to use it in the context of children and young people living with diabetes?
So in terms of children and young people with diabetes, we have good access. So we have the NICE guidance that is out, and that is good evidence for all teams across the United Kingdom that children are able to, so all with type 1 diabetes should have fair access to the continuous glucose monitors, insulin, standalone insulin pumps, and the new artificial pancreas, which is also known as the hybrid closed loop system.
So all children and young people living with type 1 diabetes in the UK are entitled to those technologies that we spoke about. So the continuous glucose monitoring, the insulin pumps, and then the closed loop hybrid system, otherwise known as the artificial pancreas. And is it all done, all that education, is that done within the home? Do you have those, I think you call them introduction to technology days. Do you do those? Do you do that as well in your unit?
So with our children with type 1 diabetes, we don't do introductions to technology. What you will find in paediatric diabetes teams, we're usually quite good at starting technology from diagnosis. So you'll find that a lot of the introductions are done on a one-to-one basis. We used to try and do those introduction to technology days, but we found that you're always going to get your, how do I say this in the best? You're always going to get your well-engaged families going to those events. But the idea of these events is that you want everybody to have access to the technology. So we just found that the one-to-one approach works better. And
do you always go into the home?
We always go into the home.
So children, young people who've got the high HbA1cs, that blood test that we spoke about, which is a sort of marker of how things are doing with your diabetes and your blood glucose levels. So once somebody's got a high HbA1c, you'll be going into the home.
Yes, yeah.
The Davina squad is coming to your house, looking in your cupboards.
Yep, or we go into schools as well. So if they try and run away.
Sorry, Davina, is that to educate the schools?
So that's to educate the schools, but we also go in to review the children as well. So we give them more support. That can be weekly, every 2 weeks, every 3 weeks. We tend to let the child and young person decide on that. So we usually say, look, we're here to support you. We know things aren't where they need to be. What can we do to support you? This can't go on much longer. We want you to live a nice, long, healthy life. How long would you like us to visit you for? It's not always face to face, because we have to let them have choices as well. So sometimes it could just be a daily WhatsApp little check-in from myself or one of my colleagues. It can be a weekly video WhatsApp call or emails. It really is dependent upon the child and family.
Davina, I'm going to put you on the spot. Okay, as I said, you have got amazing, fantastic results. Honestly, this is the golden nugget. What are the key things that we all can take from what your award-winning team that has achieved this? How do we, the rest of us, do it? Because what we all want to do is to improve everybody's health. So how would we do it? How can we get that out there?
I think it's the outreach work. It's doing that one-to-one implementation. It's demystifying the technology. A lot of families are concerned that it won't work for them. A lot of the families are concerned about wearing things, about people finding out they have a condition. It's really getting to know your families one-to-one, because before you can really work with them and improve those outcomes and give them the right type of support, it's about understanding them. It's doing those home visits, it's doing that outreach work, going into the schools, if needed, getting that extra support. I know we have the hybrid closed loop systems now, which make implementation into technology so much easier. I know in the paediatric population we have better access to that in terms of funding. So it's showing the families how they work. I think it's as healthcare professionals as well, it's about educating ourselves and making sure that we are aware of the latest technology, that we're aware of the latest treatments, so that we can educate others. Those are the biggest things.
Sorry, Davina. And hybrid closed loop, you use some terms there people might not understand.
Sorry, so that is the artificial pancreas. So that is when you wear a continuous glucose monitor or flash glucose sensor, which have actually turned into continuous glucose monitors as well. They now communicate with insulin pumps. So they're continuously reading your glucose readings every 3 to 5 minutes, and they will give insulin automatically depending on the trends of your blood glucose readings. So we've seen evidence now that this is the best treatment for those with type 1 diabetes. So that's what the artificial pancreas is.
Yeah, that's what most people would recognise it as, the artificial pancreas. So that's what your pancreas would be doing naturally if you weren't living with type 1 diabetes, if you didn't have that autoimmune condition. And do you think there are any... I'm going to ask you probably a couple of questions, because, I know there's going to be loads of questions in the Q&A. Two things. So do you think there's anything specific about your team that helps you to achieve these wonderful results? So, is it that your team looks like your population? Is it that you've got loads of healthcare professionals in your team? So that's the magic thing that we all need to do. Is it the mandatory, they've got to see the psychologist? What in your team do you think might be helping you guys to achieve this? And then you've got to leave us with something about technology, why it's so important, and what we need to do.
So I think the biggest thing about our team is that we have the confidence in the technology. It's really that we have a good understanding. It's that we've educated ourselves in how it works. And we want to make sure that our patients have access to it. We've worked really hard in ensuring that we could get the funding. I think that can be a really big barrier to a lot of teams. It's gaining the funding. It's doing that outreach work. We are really persistent in our team. If we have patients that don't come to their appointments, we are very good at coming out and finding you and bringing you in. It's not that we have, the staff in or anything. It's just that we kind of just go that extra mile. We just understand our patients. We go out, we go the extra mile, and we do the work. We educate ourselves. Even with type 2 diabetes, we're trying to kind of start loads of new projects now in our area. How can we reduce type 2 diabetes? How can we get them at the stage of pre-diabetes? That's the biggest thing.
Yeah. So the Davina squad is one of the things, as I'm going to call it. Thanks so much, Davina. Really appreciate you sharing all of those knowledge and skills and your expertise with us. So tell us, what's the key to technology? Why should we all be encouraging it? Why should we educate ourselves primarily first, so that we can then give that information to the people that we serve?
Yeah, it's just not to be afraid of it. We've seen the research out there. The research is it's amazing. It shows that with the right use of technology, you will get good outcomes. We have patients with HbA1cs of 48 and below. The new hybrid closed loop systems we know work really well. I would say if you're really anxious with the technology, use the company representatives to help you. We're more than happy if you contact our service for support, to shadow us. I think it's really important that as peers that we support each other, that we share how services work, because there may be another service out there that might be doing something that we could also implement. So I think it's the transparency within the services. We need to work together so that ultimate goal is reached, that all of our patients have, number one, access to technology, and that we reduce those long-term outcomes and complications of diabetes as a whole.
Absolutely. Thank you so much, Davina. Thank you. I really, really appreciate it.